Consider a difficult question. What if the blood pressure value your physician described as borderline, the one they suggested simply monitoring, is actually the reading linked to the greatest risk of a silent stroke? And what if the measurement that prompted a new prescription was, in reality, offering protection for your heart? That idea may seem counterintuitive. Yet after many years of examining cardiovascular risk among older adults, one fact stands out. Most individuals over 60 are not uncertain about whether their blood pressure is elevated. What confuses them is the definition of high for a body that has been functioning for 6 or 7 decades. That misunderstanding can have serious consequences, including the loss of independence. The important question is not simply how high a reading appears. The real issue is determining what level is excessive for your age, your physiology, and your personal risk profile. There is also a value hidden within every blood pressure measurement that very few people calculate. It may predict stroke risk with greater accuracy than the figures most commonly recorded during a medical visit. A major problem with how blood pressure is discussed is the desire for a single cutoff point. People want a specific line that separates normal from abnormal. The appeal is obvious. It is straightforward and easy to understand. However, that approach leaves out critical information. According to the Centers for Disease Control, nearly 70% of adults older than 65 meet the criteria for hypertension. Yet an important detail often goes unmentioned. A substantial number of older adults who receive medication after office measurements do not demonstrate persistent high blood pressure when readings are taken correctly at home over time while resting. Their treatment may be based on a brief snapshot rather than their true baseline condition. At the same time, some people whose readings appear to fall within an acceptable range are quietly accumulating cardiovascular damage. The problem is not necessarily a single high value. Instead, it may be the pattern of their blood pressure over time, something a single clinic visit cannot fully reveal. A more useful framework begins with 3 questions. Too high compared with what? A resting baseline or a temporary reaction? Too high for how long? One measurement, 1 week, or an entire year? Too high in which component? The upper number, the lower number, or the distance between them? Each question leads to a different conclusion. Each reflects a different form of damage occurring within the body. Every blood pressure reading contains 2 values. After age 60, those values often begin moving in opposite directions, and that divergence is one of the most significant indicators in cardiovascular medicine. The upper value, known as systolic pressure, represents the force exerted against artery walls when the heart contracts and pumps blood forward. It is the pressure surge created by every heartbeat. The lower value, called diastolic pressure, reflects the pressure present between beats while the heart refills. This is the background level experienced continuously by the arteries, even during rest. With advancing age, arteries become stiffer. This process is unavoidable and part of normal biology. Elastic fibers within arterial walls gradually lose flexibility through a process known as arteriosclerosis. As arterial stiffness increases, 2 changes occur at the same time. Systolic pressure rises because rigid arteries cannot expand effectively to absorb the pressure wave. As a result, each heartbeat creates a stronger surge. Meanwhile, diastolic pressure often declines or remains unchanged because stiff arteries lose the ability to recoil efficiently between beats. Resting pressure therefore falls. The consequence is a widening gap between the 2 values. The upper number increases while the lower number decreases or stays stable. This pattern, where systolic pressure is elevated while diastolic pressure remains normal or low, is known as isolated systolic hypertension. Among adults older than 60, it is the most common form of high blood pressure. Most hypertension cases in this age group follow exactly this pattern. It differs substantially from the hypertension typically seen in younger adults, where both values tend to increase together. This distinction matters because isolated systolic hypertension carries its own risk profile. An extensive analysis based on data from the Framingham Heart Study demonstrated that elevated systolic pressure in older adults was among the strongest independent predictors of stroke, heart failure, and cardiovascular death, even when diastolic pressure remained completely normal or was relatively low. Therefore, a reading with a lower value of 72 should not automatically be considered reassuring simply because the diastolic measurement appears healthy. The upper number alone may still contribute to significant cardiovascular damage. Research has also attempted to identify treatment targets more precisely. One of the most influential studies in this area was the SPRINT trial, published in the New England Journal of Medicine in 2015. The trial enrolled 9,361 adults, the majority of whom were older than 60. Researchers asked a straightforward question: would more intensive blood pressure treatment reduce cardiovascular events? The findings indicated that it would, although important limitations accompanied the results. The SPRINT trial showed that targeting a systolic pressure below 120 reduced the primary composite cardiovascular outcome, including heart attack, stroke, heart failure, and cardiovascular death by 25%. It also lowered all-cause mortality by 27%. The SPRINT trial also revealed an important trade-off. While more intensive treatment lowered cardiovascular events, it was linked to noticeably greater rates of acute kidney injury, severe drops in blood pressure upon standing, episodes of fainting, and disturbances in electrolyte balance. These are genuine concerns. They must be carefully balanced against the cardiovascular advantages, especially for people older than 75. For that reason, any blood pressure range should be viewed from both perspectives. There are dangers associated with uncontrolled pressure, but there can also be risks when treatment pushes values too low. For adults between 60 and 74 years of age, a resting systolic measurement under 130 represents the preferred target range. A systolic value from 130 to 139 remains acceptable, though it deserves close observation. A reading between 140 and 149 enters an early caution zone. It is not yet an emergency, but it calls for lifestyle adjustments and a meaningful discussion with a physician. When systolic pressure remains at 150 or higher for 2 weeks or longer, the level is considered excessive and requires medical evaluation. Among adults 75 and older, the objective remains a systolic value below 140. However, the intensity of treatment depends greatly on kidney health, susceptibility to fainting, blood pressure drops while standing, and overall physical condition. A persistent systolic reading of 150 or above is considered too high regardless of how the individual feels. For diastolic pressure, the lower number, anything below 80, is regarded as optimal. Values between 80 and 89 should be monitored carefully. A consistent reading of 90 or higher places continuous stress on blood vessels and kidneys. There is another side of the equation that many people overlook. For older adults, a diastolic measurement below 60 can also present significant danger. This form of risk receives far less attention. Research published in the Journal of the American College of Cardiology, using information from the ARIC cohort, reported that a consistently low diastolic pressure under 60 was associated with substantially increased rates of subclinical myocardial injury and coronary heart disease events. The issue was not excessive pressure. The problem was insufficient pressure between heartbeats to adequately perfuse the heart muscle itself. Another investigation published in the journal Hypertension reached a similar conclusion. Among elderly individuals with isolated systolic hypertension, a diastolic value at or below 60 independently predicted mortality. One patient, referred to here as Evelyn, was 77 years old and had retired from a career as a librarian in Georgia. She arrived feeling dizzy, drained of energy, and concerned about her health. Her systolic pressure was well managed at 126. Yet over several months, her diastolic value had fallen to 54 while taking multiple medications. As a result, her heart was not receiving enough blood flow between beats. Her treatment plan was adjusted carefully. Within a month, her diastolic pressure rose to 68. The dizziness disappeared. Her energy returned almost at once. The problem had not been excessively high blood pressure. Attention had remained fixed on lowering the upper number while the lower number quietly fell into a harmful range. Both values matter. Focusing on only one can create problems that remain hidden beneath an apparently successful result. There is another measurement that rarely receives attention during a routine office appointment. It can be calculated in only a few seconds from any blood pressure reading. This value is called pulse pressure. Pulse pressure is determined by subtracting the diastolic number from the systolic number. A reading of 148 over 78 produces a pulse pressure of 70. A reading of 132 over 82 produces a pulse pressure of 50. That difference between the two numbers is one of the strongest indicators of cardiovascular risk in older adults. A major Framingham Heart Study analysis published in Circulation demonstrated that pulse pressure predicted serious cardiovascular events more effectively in adults older than 60 than either systolic or diastolic pressure considered separately. The same analysis showed that after age 60, lower diastolic pressure became inversely associated with heart disease risk. In other words, a wider gap signaled greater danger. The explanation is straightforward. Pulse pressure reflects arterial stiffness in real time. As arteries become rigid, systolic pressure rises while diastolic pressure falls. The gap expands. A larger separation means the heart must work harder during every heartbeat. That increased effort places additional mechanical stress on artery walls, including the coronary arteries responsible for supplying the heart muscle. Certain ranges are especially important. A pulse pressure below 40 generally indicates that arterial elasticity remains well preserved. A range between 40 and 60 is acceptable, though long-term tracking is advisable. When the value exceeds 60, it enters a warning range associated with meaningful arterial stiffening and elevated cardiovascular risk. A pulse pressure above 80 represents a serious concern. Consider a blood pressure reading of 165/75. Many individuals focus entirely on the systolic value of 165, yet the pulse pressure equals 90. That figure suggests substantial stress affecting arterial wall function. In some cases, it deserves equal attention or even greater attention than the upper number itself. Any recent blood pressure measurement can be used to calculate this value. Subtract the lower figure from the upper figure. If the result exceeds 60, it is worth discussing specifically during the next medical appointment. Another critical concept is often overlooked. Blood pressure is not static. It changes throughout the day, and sometimes those fluctuations are substantial. There is one period that carries particular importance for older adults. It is known as the morning surge. During the first 2 hours after waking, beginning when the eyes open and extending to approximately 90 minutes afterward, blood pressure normally rises sharply. This increase is driven by the release of cortisol and adrenaline as the body transitions from sleep to wakefulness. Heart rate increases. Activity within the sympathetic nervous system accelerates. In younger, healthy adults, this rise is usually moderate. In older individuals with stiffened arteries, however, the increase may be dramatic. Readings can climb 20, 30, or even 40 points above nighttime baseline levels. Research published in Circulation found that the period between 6 a.m. and noon accounts for a disproportionately large share of strokes and heart attacks among older adults. The morning rise in blood pressure appears to be a major contributor. A landmark prospective study involving 519 elderly hypertensive patients found that those experiencing a pronounced morning surge faced a relative stroke risk of 2.7. That was nearly 3 times higher than those with a less pronounced surge, even after adjusting for average 24-hour blood pressure. The practical implication is important. Someone who measures blood pressure only once each day at 3 p.m. may be capturing the most stable and least concerning period of the day. A reading taken within 30 minutes after waking, before coffee, before medication, and before physical activity often provides much more clinically useful information. One patient, referred to here as Gerald, was 71 years old and had retired as a school principal in Virginia. His afternoon readings remained consistently around 132/78. Those numbers appeared entirely acceptable. He felt well. Nevertheless, he was asked to record measurements for 2 weeks at 3 specific times, within 20 minutes after waking, at noon, and before bedtime. The results revealed a very different pattern. His morning systolic readings averaged 158. The same individual who appeared well-managed during the afternoon turned out to have dangerously elevated readings during the first 2 hours of each day, 5 days every week. Those higher values occurred during his morning walk and around the time of his first coffee. A simple adjustment was made to the schedule of one medication he was already taking so that it provided stronger coverage during the early hours. His morning systolic average fell to 134. His afternoon numbers remained exactly the same. Without those morning measurements, the underlying risk would have remained hidden. That is why checking blood pressure shortly after waking is so important. Everything discussed so far depends on one critical factor. The readings must be accurate. Unfortunately, inaccurate measurements are far more common than most people realize. There are 5 errors that appear repeatedly. Each one can falsely increase a reading by 10 to 20 points. When several occur together, the total distortion can reach 30 to 40 points, creating a number that does not reflect true blood pressure at all. The first mistake is measuring immediately without resting. Blood pressure rises quickly after physical movement, even after something as simple as walking to the bathroom. Research has shown that skipping an adequate seated rest period can significantly raise the result, especially in individuals who already have elevated pressure. That is precisely when accuracy matters most. Current guidance from the American Heart Association recommends at least 5 full minutes of quiet seated rest before taking a measurement. 5 uninterrupted minutes should come before every reading. The second mistake involves placing the cuff over clothing or allowing the arm to hang unsupported. The cuff should always touch bare skin. The arm should be supported at heart level. It should not dangle and should not rest in the lap. Simply allowing the arm to sit too low can increase a measurement by 8 to 10 points, because of the hydrostatic effect created by blood shifting downward. The third mistake is using an incorrect cuff size. A standard adult cuff placed on a larger arm can produce readings that are falsely elevated. This problem is extremely common and often goes unnoticed. Anyone uncertain about cuff size should ask a pharmacist to verify that the equipment is appropriate. The impact is greater than many people expect. The fourth mistake includes measuring with a full bladder, sitting with crossed legs, or talking during the procedure. A full bladder can raise systolic pressure by an average of 10 to 15 points. Crossing the legs may contribute another 5 to 8 points. These findings have been confirmed in multiple controlled investigations, including the work of Keel Smith and Price Daniel in 2001. Conversation during the measurement can increase readings by 10 or more additional points, as documented in research involving automated blood pressure monitoring. Combined, these factors can create 25 to 30 extra points that have nothing to do with actual cardiovascular status. The fifth mistake is relying on a single reading. Blood pressure naturally varies. One isolated measurement offers very limited information. 2 readings should be taken 1 minute apart. The lower result should be used. More importantly, attention should be focused on trends. At minimum, readings should be collected for a full week during both morning and evening periods. For adults older than 60, the recommended procedure is straightforward. Sit quietly for 5 minutes. Keep both feet flat on the floor. Support the back. Place the cuff on a bare arm positioned at heart level. Take 2 measurements separated by 1 minute. Repeat the process twice daily. The first session should occur within 30 minutes of waking. The second should take place during the evening. Continue for 7 consecutive days. Average all results together. That average reflects true blood pressure far more accurately than a single office reading and should be the basis for treatment decisions. Another frequent question concerns the point at which a high reading shifts from something that requires observation to something demanding immediate action. The answer depends on symptoms. A high reading without symptoms should be addressed calmly and systematically. Sit down, rest quietly for 10 minutes, breathe slowly, measure again. In most situations, a concerning number falls noticeably after genuine rest. Stress, anxiety, caffeine, and even concern about the reading itself can temporarily increase blood pressure by 20 to 30 points. A different situation exists when a high reading is accompanied by specific warning signs. If systolic pressure exceeds 180 or diastolic pressure exceeds 120, and any of the following symptoms are present, emergency services should be contacted immediately. Do not drive yourself. Do not wait for the symptoms to disappear. Warning signs include a sudden severe headache unlike previous headaches, chest pain or chest pressure, unexpected difficulty speaking or understanding language, changes in vision or partial loss of sight, numbness or weakness affecting one side of the face, arm, or leg, or sudden and severe breathing difficulty. When these symptoms occur together with a very high reading, they may indicate a hypertensive crisis. In that situation, blood pressure may be damaging organs in real time, including the brain, heart, kidneys, and eyes. Every minute matters. At the same time, many people record values in the 170s or even 180s without experiencing any symptoms at all. This is especially common during periods of stress, anxiety, or inaccurate measurement. Such situations do not automatically require an emergency room visit. They require rest, a repeat measurement, and contact with a physician either the same day or the following morning. Understanding the difference between a temporary spike and a true crisis is essential. That distinction may prevent years of unnecessary treatment, or it may save a life when immediate action is needed. The key points are clear. For adults between 60 and 74, the target systolic pressure remains below 130. Values from 140 to 149 deserve attention. Persistent readings of 150 or higher are excessive. For adults 75 and older, the goal remains below 140. A consistent systolic value of 150 or more is too high regardless of age. Diastolic pressure above 90 is harmful. Yet a diastolic value below 60 can be equally concerning and is frequently overlooked. Pulse pressure should also be calculated. This is the difference between the upper and lower numbers. Below 40 indicates healthy arterial elasticity. Above 60 signals caution. Above 80 points toward significant arterial stiffness and increased cardiovascular risk. The morning surge remains one of the most dangerous periods of the day for older adults. For that reason, the morning reading is often the most valuable measurement collected. Many people never check it. Proper technique also matters. 5 minutes of rest, a bare arm, 2 measurements, twice each day, 7 consecutive days. Average every result. Those steps provide a far more accurate picture than any isolated reading. A high value without symptoms calls for calm reassessment and monitoring. A high value accompanied by severe and sudden symptoms requires emergency care without delay. Blood pressure should not be viewed as a final judgment. It is information. It reflects the ongoing interaction between the body and its environment. Understanding these patterns allows better decisions and a clearer picture of cardiovascular health. If this information has been useful, share it with someone who may benefit from understanding their blood pressure more clearly. Accurate knowledge can make an important difference for the people we care about. Please leave your thoughts about this content in